TopMedTalk.
Welcome to TopMedTalk. Have we reached a point where we can fix interoperative hypotension? Can we now, in practice, predict, diagnose and treat its underlying causes? Today's piece is entitled Perfusion, Not Just Pressure. Predict, diagnose and treat underlying cause. Don't just squeeze. This conversation originally formed part of TopMedTalk's exclusive coverage of the International Anesthesia Research Society meeting, organised with the Association of University Anesthesiologists and the Society of Critical Care Anesthesiologists. It's a conversation between Monty, Mythen, Desiree, Chappell and Mike Grocott with Wael, Saasouh, Regional Director of Research at NorthStar Anesthesia.
Desiree, you've started that journey. You've started to see if you can fix the hypotension, but not just the hypotension, the real issue, which is the hypoperfusion.
Yeah, for a little context for those that are listening, NorthStar is an organization of over 200 facilities across the U.S. in disparate locations, and we have over 3,000 providers. So you can see that we have a little mini NHS going, or at least the provider side. You know, it's a huge task. Wael is taking this on to see how we can scale and reproduce the things that we're doing. An example of that is what you're referring to, Monty. We're working on in one of our facilities in Louisville, Kentucky, where I happen to do my clinical work. I've been within the system for a very long time and realizing we still do have interoperative hypotension. We've seen the numbers. It is a reality for us. I think when we saw that as a group, kind of said, well, there must be a way that we can avoid this and do better by our patients. We kind of thought we were doing the right thing, but maybe not. So what we are looking at from a quality improvement perspective is figuring out how we as clinicians can change practice, use different types of interventions, technology, refine the algorithms that we've been using to really make a difference and avoid hypotension altogether. At our institution, we do very large, multi-level, complex spine, one of the busiest spine centers within the U.S., Leatherman Spine Center. Steve Glassman chair that program. And it's been a really interesting collaboration with Leatherman and Norton Healthcare and NorthStar. And I think our clinicians are really excited. We have about 26 patients under our belt now and looking forward to see what we can do to improve care.
So, and we'll loop back that in a moment. I'll come back to you, Wael, about the design, and then I'll come back to Mike about the concept of registry nested trials and efficiently answering these questions. Desiree, I think you've specifically been looking at hypotension prediction index, which has attracted a little bit of attention in various different editorials and commentaries recently, where the academics want to have opinions.
Yeah.
As one of our colleagues in South Africa used to say, largely uncontaminated by data. But you've been having some real world experience.
We have, yeah. So full disclosure, working with Edwards Life Sciences, using their newer technology, the Hemisphere and Acumen Predictive Analytics and HPI, the Hypotension Predictive Index. You know, I will say that our group, we have been using advanced hemodynamic monitoring for quite a while now, more than several years, probably 7 or 8 years, and transitioned to the new technology. You know, it's so interesting because I always felt like I was doing a good job, really have a great handle on all the different hemodynamic parameters. But bringing in this new number, it took a little while to get used to figure out what it really meant to our patients, what it meant to me and the whole picture. But it's been enlightening and just trying to figure out the different interventions that we do to avoid hypotension using vasopressors versus fluids versus inotropes, seeing how the hemodynamic parameters change, having confidence with the monitoring technology and those numbers, and really figuring out how do I use that to not necessarily predict hypotension that's happening, you know, within 5 minutes or within a couple minutes, which if we're waiting for some of those index numbers to alarm, but looking a little bit earlier than that, when we start to see some trends moving along, saying, wow, I see some trends happening. HPI is starting to go up. Can I start looking at what the possible causes of that may be? And can I actually avoid hypotension altogether? Because
some of the recent criticisms have been that because of where the alarm is set for HPI, when the alarm's allowed to go off, you can already kind of see that you're going over the edge.
Yeah.
Because it's set very late. It's a kind of you're about to crash alarm.
Yeah.
So at that stage, if you just look in isolation at that, the HPI kind of mirrors the blood pressure.
It does.
And then if you treat, the blood pressure measures the HPI, which is kind of not the point.
Right.
It's the half an hour before that is the interesting bit. And are you seeing at lower levels of HPI changes happening in the hemodynamics?
We are, for sure. I always like to say it's kind of like my Volvo. When I'm in my Volvo and I'm not hitting the brakes when someone in front of me is braking, it's going to start alarming and hitting the brakes. But I have lane control and some of these things saying there's traffic coming up, all these different things, notifications that things may be occurring here in the future. And so this is the same way. And I will say, if we look at the index number, 85 is the alarm. Well, if you're seeing an HPI of 85, like you said, you're about ready to crash. Your mean is already dipping down into the lower 70s and upper 60s. But we're noticing that when we start to see an HPI of about 50, start really looking at where are other numbers? What are our trends doing? What's stroke volume doing? What's cardiac index doing? Are those numbers drifting? What's the blood loss? We start seeing changes there around 50 to 60. And then that's when we start saying, well, maybe I'm going to treat those or give a little bit more fluid, make sure my index is fine. Is it a cardiac? We were seeing cardiac depression versus like fluid.
So you're not
issues.
just giving a vasopressor when the MAP gets to 70?
No, absolutely not. Yeah.
So I'll come back to you in a second, Desiree. So while you're going to try and address this with an academic slant, so you've got IRB approval to do a form of a study. Can you expand on that?
The study is basically trying to utilize this technology to see if it makes any difference. So we have historical data from the Norton Center. We know our incidence of hypotension. We know what we've been seeing for the past couple of years, say. And this technology is very enticing. We know that if you predict it, you're probably going to treat it better, but we don't know that for sure. So we want to have some practical data that tells us, yes, if you use this in a certain way, are you able to follow the institutional guidelines a little bit better? Are you able to mitigate some of that hypotension that you can prevent compared to what we've been doing over the past couple of years? And the intent is the same. The intent is always to avoid hypotension because it's better for the patients. We now have a slightly different lens to look at it and to interfere probably at an earlier stage. And once we link that with outcomes, hopefully that also translates into better patient outcomes, less adverse events afterwards, and so on.
So when you get the earlier signal, the extra bits I think I'm hearing, and I think we all know this, but just for everyone else's sake, is when you look behind the thing that says you something is going on, it tells you about preload, afterload, and contractility. And then you choose one of those three therapies or two from three. You don't just keep giving phenylephrine.
Absolutely.
Okay.
Because if we rely on one of these methodologies, we tend to overtreat in one direction and ignore some of the other directions. And when you have all this data in front of you in a more clear and concise manner, you can individualize your treatments, which might even change for the same patient at different points during the surgery. So when you have all that information available to you and it gives you a clearer indication of what the cause of the hypotension might be, or the upcoming hypotension might be, then you can treat it a little bit better, we would hope.
So in stage one, and I know a bit about this because I've been talking to you about it, I think the first thing you're doing is you're testing the feasibility of your algorithm and you're testing compliance with it.
Correct.
Mm-hmm.
Yeah.
We've had a Fedora protocol in place for years.
To expand on that a little bit, the Fedora?
Yeah. So it's a stroke volume protocol that integrates hypotension. It dives into fluid bolusing and then looking at cardiac index and blood pressure. And so we've had that in place. And what we are really trying to look at is integrating the relief trial and just going ahead and giving our patients a fluid bolus up front, co-loading, and then looking at cardiac index. And then if we start to see hypotension or that the HPI may be predicting hypotension, then we look at doing another fluid bolus. And then lastly, we would be adding a vasopressor. So that's really at the bottom of the list now.
So just so we throw them into the show notes, the Fedora term relates to a study called Fedora.
Thank you. That's what you were getting at.
And we'll put that into the show notes, the link there.
The link.
And the algorithm there that looked very successful in terms of outcomes, multi-center, addressed preload first, so it gave fluid boluses to maximize stroke volume. Then it looked at cardiac index, so it addressed flow. And then and only then it addressed pressure.
Yeah.
So I think you're replicating that in achieving your goal. And you also mentioned relief.
Yes.
Which we'll put in the show notes again, which was being moderately liberal is better than being restrictive.
Right.
Okay, so using HPI and you're looking at compliance with that algorithm.
Yes.
Now, when you get compliance up, what's your ambition for compliance?
You mean compliance
with the providers? Because if we look at the literature recently, we've had examples where it's been 50%, for example, compliance. It's slightly worse than if you didn't ask for compliance, which is usually about 65%.
So we've really pushed this with our clinicians on the ground to say, if you're going to be taking care of your patients and participating in this, we're asking that everybody really sticks very closely with the protocol. So whether or not we get 100%, I don't know about 100%, but I think that we'll definitely reach above 90%, I would hope so.
Anecdotally, because we've seen recent literature suggesting that almost everyone's getting phenylephrine now.
Yeah.
And things aren't getting better, they're getting worse.
Yeah.
Even though hypotension's getting less.
No.
Are you noticing other treatments that are being used any more often?
Anecdotally, I do feel our use of crystalloids has increased. Our volume has increased. As I've talked to providers, I think people thought they were giving plenty of fluid. I mean, we definitely swung the pendulum to a restrictive approach about 5 or 6, maybe 8 years ago. And so I think it's been slowly chipping at, it's okay to give some fluid in these prone spine patients. And so I think this has highlighted that even more, that they didn't realize they still were restricting fluids. So I think we've increased our fluids. I think we still have a little bit of reliance on vasopressors, but I think people are reaching back in for inotropes that we previously kind of stepped away from for a little while.
I know Mike's chomping at the bit to come in with a few things.
I know.
I'm going to tee up one last ball.
Okay.
And then we'll let him hit a row of them. Okay. You mentioned that the Leatherman Spine Institute is part of a national registry of outcomes.
They are.
So they know the outcomes on thousands of patients, and they have access to tens or hundreds of institutions.
Yes.
So your outcome measures, if you and when you progress this, are already available there. Is that correct?
They are, yes. That is something that Dr. Glassman was heavily involved in starting, the National Spine Registry. They have already been looking at different outcomes, surgical site infection, things like AKI and spinal cord monitoring. One thing that we've talked to them about is looking more closely at stage 1 AKI. So that was something that they never really looked at before, and fluid totals and vasopressors.
So for the record, in the short term, in the feasibility, you're looking for high compliance.
Yeah.
Correct.
And some sort of signal, I believe, that one of those outcomes will be a bit better compared to...
True.
Which one are you going for as your main...
Mostly the acute kidney injury.
Yeah.
Okay.
Yep.
Yeah.
As a kind of
canary
in the
marker
Yeah.
of how well we're adhering to this and whether it matters or not. Because it's one of the easier ones that are measured. We can look at cardiac markers as well. We can look at a few other things. But it seems to be one of the more obvious
ones to go
targets
for.
to go for. Yeah.
So, Mike, I know we've got a list of questions and comments there. And at the end of it, I want you to touch, if you would, on the concept of registry nested trials and studies. Save that one and ask your other questions first. But that would be my question for you at the end.
It's been really interesting to listen to you talk about this study. I guess the thing that is implicit that maybe we should make explicit, thinking over the number of years that we've been involved in different fluid studies, is this the U-shaped curve concept. Mm-hmm. So you can clearly do harm if you give too much fluid.
Right.
But we've also got an increasing amount of evidence that you can do harm by giving an inadequate amount of fluid. And that was, there's the so-called Bellamy curve from an editorial in the British Journal of Anesthesia back in about 2005. But there's a lot of data to support that now. So we've got big epidemiological data showing a sweet spot of not too little and not too much fluid, looking at tens or even hundreds of thousands of patients. And then we got the relief study, touched on it already, a randomized controlled trial comparing full-on restriction with something a little bit more liberal. And I think perhaps to the surprise of many, but entirely consistent with the Bellamy curve, the outcomes were better in the group that had a little bit more fluid. So not lavish amounts of fluid, but maybe a positive balance of 1 to 2 kilos. And you've touched on with your primary
therefore
outcome,
1 to 2 litres.
Yeah. 1 to 2 litres. Yeah. And the kidneys were definitely a bit happier. And I think that was a big turning point for a lot of people who otherwise were going to I must give less and less from an enhanced recovery perspective.
It's very hard to generalize for countries, but I haven't been anywhere or talked to anyone here recently who isn't restricting.
Yeah, it's still ubiquitous.
I mean, by here being the United States of America. It's a very, very big continent to generalize like that, but it seems to be extremely common and being reported in multi-center studies in the literature now as well.
Fascinating that the enhanced recovery literature, which predominantly came from Scandinavia at the very beginning, and they didn't say restriction.
They never said no.
It was avoidance of fluid overload as opposed to restriction. But, language has huge impact. And that word restriction, I think, has potentially caused quite a lot of harm.
One interesting aspect of this is that this approach to restricting fluids is not only sticking to anesthesia providers, it's bleeding over to surgical colleagues who read some of that and then blanket statement, everybody gets 500 mLs of fluid for a robotic surgery, which is not personalized, and it may not be appropriate for everybody. For some patients, yes, it would be appropriate because there are other considerations like bladder volume and all that. But it's a good time now to kind of enhance the message a little bit, to tell people how you should approach this topic, not just everybody gets less fluids or everybody gets more pressors.
And the phenylephrine infusion seems to be becoming almost normal.
Right.
Well, I mean, if you think about it, when we went with IARS and that term fluid restriction, which, by the way, plug for TopMedTalk, talking to Brigitte Brandstrup last summer about the term fluid restriction. We went through the whole thing. She wishes she never branded it like that, or that terminology ever came out. But with the IARS protocols, if we fluid restrict and we can't give any fluid, we want to avoid IOH because that's what the literature is saying. IOH is bad.
Now you set your alarm at 70, allegedly, is the secret sauce.
Right. And what else do you do? All you have are vasopressors at that point. So, I mean, we've really limited and kind of painted ourselves into a corner with our ability to treat hypotension and actually manage hemodynamics instead of just treating a blood pressure.
UK anecdote, Mike, which we've shared before, our enhanced recovery program about 2010, when we were in sort of peak early rollout, we started to see the same signal, didn't we?
We did, and in very low risk patients. I mean, we particularly, one of my colleagues in Southampton flagged up the fact he'd been an intensive care consultant for longer than he probably cared to mention. And all of a sudden, I mean, not hundreds, but we were starting to see patients for routine joint replacements who were coming in with an acute kidney injury, and a handful of those were requiring renal replacement therapy. That was a new observation for us. And that seemed to derive from this notion of fluid restriction. I must not give fluid. And that the kidneys became very unhappy.
So we had to write national guidelines and consensus statements written by anesthesia and surgeons to say, stop already, because we have national data. So we could see at a national level the post-operative AKI rates had gone way up.
The links to the fuller conversations are available in the show notes, alongside links to the studies mentioned in that chat. Thanks for downloading TopMedTalk. Don't forget to subscribe. And of course, don't forget you can check us out on social media. We're on Facebook, we're on YouTube, and of course, we're on LinkedIn. Check that out as well. And of course, don't forget to subscribe to TopMedTalk.